Thanks for checking out the RSA lecture series. I'm Sara Jo Nixon, and I've been given a few minutes to talk about alcohol's long-term effects on cognition. It won't be a formal lecture, but the kind of conversation, albeit one way, you might hear when people talk about or describe the work that they believe is pretty important. When we talk about alcohol-related effects, I think we kind of have to separate two general things. One is that cognitive changes or effects and impairments that happen during acute withdrawal and detoxification. This is a medically critical condition and needs to be overseen with medical oversight. But what we sometimes don't understand is that alcohol's effects on cognition extend beyond that period of acute intoxication. The DSM-5 estimates that about 30 to 40% of individuals who meet criteria for an alcohol use disorder demonstrate clinically significant cognitive impairment. But even more than that percentage, 50 to 80% of individuals who participate in studies looking at the long-term effects of alcohol on brain demonstrate statistically significant poor performance than do their community controls. That is, individuals at the same age and the same education. So while these are not clinical levels of impairment, they are certainly the kinds of impairment that impact psychosocial adaptation, the workplace, and relationships with friends. One of the other things is that this deficit can't be accounted for, these deficits, by things like comorbid medical conditions that also impact cognition. When we talk about 50 to 80% of individuals in these studies showing significant deficits, obviously another percentage do not. That is one of the hallmarks of alcohol-related neurocognitive deficits. That is the heterogeneity. Individuals differ a lot between themselves in terms of the degree to which they may show an impairment, but they also differ within themselves depending on the kinds of tasks or tests that are administered. While that's the case, when we think about cognition in general, we can sort of think about some general functional domains, such as executive functions, which involve problem solving and abstraction, behavioral inhibition kinds of things, verbal learning and memory, learning people's names, remembering the list that you're supposed to get at the grocery store, visual spatial learning and memory, such as map reading and navigation, perceptual motor skills. Some of those seem simple, but in reality, they are really important in how efficient we are in terms of picking up pencils and being able to operate with them, and language reception and production. And what we know is that significant impairments across all of these domains can be observed with long-term alcohol use. Now, how long do they last? Well, it varies. How long they last may be a few weeks, but it may be months or even years. So when we talk about, I want to come back to this theme that when we talk about alcohol-related neurocognitive deficits, we are not just talking about the disruption associated with the very early days of abstinence or that period of acute intoxication. We're talking about weeks, months, and perhaps even years into the future. It isn't just the behavioral kinds of things that we can get measures on, like performance on learning a new list or the things I just talked about. We also know that there's disruption in the brain's neurophysiology. This is a common example called the P3 dampening. If you look at neural activity through the EEG using scalp electrodes, non-invasive ways of measuring things like you might if you were being evaluated for seizure disorders, you can create certain kinds of tasks and see whether or not the brain's electrical responses change differently for individuals who don't have an alcohol use disorder versus those that do. The P3 occurs about 300 milliseconds after the presentation of a novel but meaningful stimulus or target. So that, for instance, you might be seeing a series of dots, and 80% of them might be green, 20% of them might be red, and your job would be to track the red ones, just to keep mental count. When that happens, your brain creates or elicits this P3 that occurs in response to those rare but meaningful targets. It's a way of sort of being a context updating kind of mechanism. And what we find is that individuals who have alcohol use disorders show a dampening of the amplitude of this P3, suggesting a deficit in the ability to update memory context. We can get it with a lot of other measures of neurophysiology as well. So it isn't just the P3. We can get it when we're looking at things like processing sentences or listening to tones that match or don't match. So we have a broad array of neurocognitive or sort of traditional tests of neuropsychology, as well as brain electrical activity. And as I'm sure you'll hear in other lectures, changes in the underlying brain structure as well, that suggest a rather mild, perhaps, but generalized dysfunction. It seems to permeate almost everything that the brain does, but it isn't equally severe across all of those domains. Is it specific to these kinds of tasks per se? Maybe you have to have only very well characterized tasks that are, specific and really honed to find cognitive deficits. Well, the answer is no. Furthermore, it isn't usually poor performance on these kinds of laboratory tasks that produce the largest challenge for individuals. Rather, it's things like problem solving in the real world. And there's a literature on that as well in terms of alcohol use disorder. We could look at this problem solving in two ways. Impersonal problem solving, and that's things where there are problems in isolating the relevant factor when facing some tasks. You can see how that could be a really big problem in the workplace. You're trying to navigate a problem you haven't solved before. And the second, it's an interpersonal problem solving deficits. It's the selection of poor response alternatives, for instance. So let me give you an example. This is from the adaptive skills battery. We have now used it in several tasks over decades and been able to show its sensitivity and reproducibility. This is an example. They're given vignettes, and individuals are asked to simply say, what is the typical response you would give? And what is the best response you would give? In this case, it sets up a workplace sort of environment or amongst friends where a confidence has been broken. And using a set of standard scoring sheets, we determine the sort of efficiency or effectiveness of the responses that people might provide. And what we find is individuals with alcohol use disorder can produce similar best responses. That is, if you say, what is the best thing a person could do? They can come up with that. But when you ask them, and what's the typical thing you would do? Their response is much less effective than are the community controls. And it is the same for men and women. The other thing is that related to this interpersonal problem solving has to do with emotion identification and processing. Clinicians, family, friends, individuals who have worked with individuals with alcohol use disorder often recognize these problems in identifying emotion appropriately, that is labeling it, processing it, and working with the nuanced components of interpersonal relationships. This extends not just to determining whether a person is angry or simply disgusted, but also in interpreting humor. And clearly, even mild deficits in these interpersonal aspects of real life can compromise social, work, and family interactions. Is there hope? We've talked about the breadth of alcohol related neurocognitive deficits, the fact that indeed can be very long lasting, but we should also note it improves with time. And it improves more consistently in conditions of abstinence. That doesn't mean that a person does not get better if they return to controlled drinking or perhaps incomplete abstinence. But the data so far are incomplete for us to really describe the trajectory differences, if there are any, between those two conditions. I can tell you that there are a number of us who are in the process of learning from an old literature on cognitive training done in the 80s with alcohol use disorder, and leveraging the developing work in brain training, like you see on all the ads about training your brain, and trying to see if we can determine a way to facilitate or accelerate the forward trajectory of cognitive recovery, believing that by itself should facilitate the longer term psychosocial adaptation, that having adequate cognitive skills will enable a more effective integration and recovery from the alcohol use problems. And we're doing that in laboratory tasks as well, and studies trying to manipulate the protocols to determine that which would be most effective. Now, this work and anybody else's work is done by a whole lot of people across a whole lot of years. And this lists a number of significant contributors, not all of them, but it also notes that we've had amazing support from NIAAA, but of particular importance is the participation of the individuals who have been a part of these studies throughout all of these years. So thanks for tuning in, and I hope you got a bit of an oversight about how broad and deep alcohol's effects on cognition can be. Thanks.